Hello, I'm Dr. Libia Scheller. I'm the medical director at the Institute of Medical Education and Research, and we are reporting to you live from the 2010 American Society of Clinical Oncology annual meeting here in Chicago. And we are so pleased to have Dr. Bradley Monk from the Creighton University School of Medicine in St. Joseph's Hospital in Phoenix, Arizona. Thank you so much for being with us today. This is truly exciting times in the area of ovarian cancer. Thanks for being with us.
My pleasure. It is an exciting time. We really have a need for new agents in gynecologic cancer. Absolutely,
and one of the exciting things is that we have you here to talk about, if you can please talk to our audience and describe the phase 3 trial that is giving options to patients with ovarian cancer.
Right, so as you know, the Gynecologic Oncology Group is an NCI-funded cooperative group that functions to study gynecologic tumors. About 7 or 8 years ago, we identified angiogenesis as a driver of ovarian cancer. We began to study bevacizumab as a single agent. We were surprised, unlike at that time colon and lung cancer, where bevacizumab was given with chemotherapy, that single-agent bevacizumab had activity in ovarian cancer. So we presented that at this meeting in 2005. It had a 20% single-agent response rate. It delayed progression for at least 6 months in 40% of patients. And so we were excited. We went back to the NCI. We went back to the maker of bevacizumab, went to our colleagues, and Bob Berger, who presented the #1 abstract in the plenary session yesterday, designed a 3-arm trial to really add bevacizumab to frontline therapy. The 3 arms, of course, the control arm was intravenous carboplatin and paclitaxel, the standard. But then the second arm added it to the chemotherapy, remember, because that's the way it was being used then in colon and lung cancer. And then the third arm had not only with chemotherapy, but a maintenance phase for about 10 months to see if we could improve progression-free survival, which was the primary endpoint. So it's been an exciting time, 1,800 patients, 600 in every arm, and met its primary endpoint. And here we are today discussing it, hopefully changing standard practice.
You know, it's interesting that in a lot of the other tumor types, you hear recurring theme about this maintenance bevacizumab. And why did you choose 10 months?
It's a great question. So this study, and it's important that you realize who went on this study, is a very poor prognosis group. Most of them had what we call suboptimally debulked or stage 4 tumors. In fact, 2/3 of them did. About halfway through the study, we expanded it to optimally debulked patients, but they had to have gross residual disease. So the best patients, the patients who had complete resection, were not included. And the median progression-free survival in that group was going to be around 14, 15 months. And so we chose 14, 15 months of treatment. And that's where that came from. As it turns out, though, the patients were even had a worse prognosis than we had anticipated. So the control arm underperformed. The progression-free survival on the control arm is 10.3 months, less than what we had anticipated. But we beat our hazard ratio estimate. We had targeted a hazard ratio reduction of 0.77. We hit 0.72. And so the bevacizumab arm 3 with chemotherapy and maintenance improved progression-free survival 3.8 months at the median. Chemotherapy and bevacizumab alone didn't have enough of a benefit to be statistically significant, although there was a very small trend. Interesting, exciting. I'm afraid, though, that people are overemphasizing this 3.8-month difference in PFS. They really should emphasize the hazard ratio reduction, because in better prognosis patients, the difference will be much greater at the median. So I think we need to consider, these studies as a hazard ratio reduction. And again, the answer is 0.717 or rounded off 0.72.
And what about these patients? How tolerable was this? In side effects, and can you discuss a little bit about that?
Sure. So since we started this study, we have identified bowel perforation as a unique toxicity to ovarian cancer patients with bevacizumab. Having said that, in this first-line therapy trial, there was no increase in bowel perforations above what we've seen in our other colon cancer and so on. So the bowel perforation rate, even in the bevacizumab-containing arm, was less than 3%. And most of those bowel perforations occurred during the chemotherapy phase, not during the maintenance phase. So that was exciting. We certainly saw hypertension, proteinuria. There were a couple of cases of RPLS, the central nervous system toxicity. But the bottom line is that there were no new toxicities identified. And as you know, Bev is now approved in 5 tumor types.
Right, so the doctors actually know, and the nurses actually have been educated on how to identify these side effects and manage them almost immediately.
So that's important. With increasing understanding and familiarity and experience with these compounds, all the VEGF inhibitors, there is a reduction in toxicity, believe it or not, because if the patient starts to get hypertension, you put them on antihypertensive therapy, then you reduce the headaches and all these other complications. And also what I said is if you identify the patients that are at high risk for bowel perforations, obstructions, multiple lines of therapy, neither one of which were allowed on GOG 218, the risk of bowel perforation will be low. So this is an effective therapy in prolonging progression-free survival, a tolerable therapy, but there's some problems. We don't have survival data. So if you as a clinician or as a patient think that you need to live longer because of a treatment and that's the only thing that matters, I can't tell you if you're going to live longer because only about 1/4 of the patients have died. That's good. We don't want patients to die. But at some point, undoubtedly, there will be some information about survival. The second part is that probably progression-free survival is only an important metric if you can delay symptoms. So if you can delay the tumor from growing, help the patient feel better, and the quality of life data are not yet mature. And we have quality of life data from the chemotherapy phase. There was no clinically important difference, but it's that maintenance phase. That's where the majority of the doses are given. That's where 16 of the 21 extra doses of Bev are given. That's where there should be might be a reduction in symptoms from the effectiveness of the drug, but I don't have that either. And then I guess other issues, how do we predict who's going to respond to bevacizumab? There's a huge repository from this trial, blood, tumor, sometimes serial samples. We need to figure out who's most likely to respond because this is an expensive and occasionally toxic therapy. So we still have lots of work to do, but I think the optimism is clear. That's why it was the first abstract in the plenary session.